Hi, guys.
Hi, Jim.
How's everybody doing?
Good.
Jim.
How
How's it
about
going?
you?
Yeah, okay. Hasn't been really good for about 40 years, though. Give me a minute, I'm
Maybe
doing
you
something.
should change that.
Hmm?
Maybe you should change that, Jim.
Well, only by dropping 40 years. And they haven't invented that yet.
You should figure that out.
Yeah. I keep trying. Like, alcohol's a preservative. I do my share. And fat's a lubricant, so that keeps the arteries going. So I do my share of that as well, but not getting any younger.
Darn.
But I'm doing my bit. Anyway, my feeling is if you're feeling really good about life, you're just not paying attention.
That sounds like a personal problem to me.
No, it's everybody's problem. Everybody's attention
You are right.
span is, everybody's attention span is no more than about 15 minutes. So they forget all the bad things, only remember the odd good thing. So life seems good to them. Which explains why there's so many alcoholics, drug addicts, and poor people.
Yeah, that is true.
See, I've got evidence. I think you only come on this just to cheer up, didn't you? Me to cheer you up.
You are the highlight of my day today.
I know, I'm told that a lot. I'll be back with you. I'm looking for something. In fact, I don't suppose I'll go anywhere, but There's 18 of you at the moment, including me. Okay, at what point is a lateral shift too chronic or too severe to correct manually? Okay, I answered this one. It was asked. I'm not being sarcastic, and I really wasn't, but it is too, if it's too chronic or too severe to correct, then you can't correct it. That means that you should try to. There's no time constraint here. There's no too bad, it looks too bad, it's been there too long. So this is the suck it and see principle, the SAS principle. See what happens when you try it. The follow-up to this, because she meant something else. So I suppose I'm not looking for a time constraint, but rather a distance from normal. Are we performing lateral shift mobilization on people with scoliosis? Now, this raises an interesting point. The lateral shift we're talking about being able to correct is the one described by Mackenzie. And this is pretty much a straight deviation. The spine just looks as if it's shifted over. And it's a really strange thing. The shoulders, it's not that there's hips going one way and shoulders going the other way, that shoulders have just done that. And more often than not, this doesn't look scoliotic. It looks like pretty much a diagonal spine. So the amount of curvature in it is fairly minimal compared to how much deviation there is. These are usually really quite severe. The pain with them is usually very severe. And they're usually misdiagnosed as disc herniations. So that's the other one. The shift from a disc herniation is not the same as a Mackenzie shift. So with these, there's a kyphosis with it plus a scoliosis. These are rotokyphoscoliosis. Now, to tell the difference, if you try and correct the disc, the patient will scream and fall over and you'll end up under them, which is pretty much how it works. So you end up trying to brace yourself so they don't come down on top of you, and you gradually have to let them go. And they're often collapse as you're doing that. So that's probably a disc herniation. The lateral shift by Mackenzie do correct, usually, unless there's a lot of spasm with it. But they usually correct. Then the question is, will they stay corrected? So that's the usual problem with these Mackenzie shifts. If they're too unstable, you can correct them. And sometimes you'll actually push them way over onto the other side. Sometimes you'll get them fairly corrected, and then when you see them again, it's gone again. So this is like any other instability. If you can correct it, but it can't stay, it's pretty much a lost cause. And this is, I'm not sure that you can do very much with this as far as rehab's concerned. You have to try, but my guess is you're not going to get very far with it. At that point, though, they're usually not as severe. So you're looking at really a cosmetic thing more than anything else. Now, I forgot who asked that question. Does that answer it for you? I should leave the names on these. I try to do them anonymously, but then I ask who wrote it. So if you don't answer me, I'll assume they're okay. All right, the answer's okay. But a lot of this stuff is suck it and see. We don't have really good research on what we're doing, which is not our fault, but the researcher's fault. We don't have really good researchers. If you look at neuro, they not only know what treatments to do, but they even know the doses of treatment to do as far as therapy is concerned. We're nowhere near that level with our research. Okay, so next question is, If a patient has an extension subluxation on the right side when doing PAVMs, would we have them laying on their left side with an extension bias? Okay, my preference is, so I think whoever asked that question, you're doing the PPIMs and PAVMs properly, like doing flexion extension with the legs, side bending, rotation. Is that what you're talking about here? Whoever this is? Now, this one isn't rhetorical. I want to know if I'm answering the question right. So when you say you're doing PAVMs, is this what we're talking about? You're doing supro-anterior glides in side line after doing flexion, extension, side bending, rotation, movement testing, rather than going from the position test to the PPIM to the PAVM. Is that what you're doing?
Yeah, let's see from Tanner. Hey, Tanner, did Eric teach you the sideline PAVMs?
All right, yeah. It doesn't matter what side you got them on. All right, it really doesn't matter what side you've got them on in that case. The extension glide is actually to come on the inferior bone of the segment. So if you're doing L4-5, you'd come on L5 and you'd push L5 supro-anteriorly to simulate L4 coming inferiorly on it. And you can do the same thing in rotation. So you can rotate them, whichever way it doesn't rotate, you can do the same extension glide. I don't do that anymore. I just don't do that. To me, I find it less reliable than doing it straight from the position test and the PPIM and PAVM. So you can do it, whatever position you found the hypomobility in, that's the position you can test it. So you don't have to lay them on the left or right side. How did you find it? Test it immediately. If you find extension loss, then test it immediately. Is that okay?
Yeah, Jim, that was my question, and I think I was talking more PIVMs rather than PAVMs, so I just incorrectly typed it.
Same thing. If you're doing, it's really difficult. Your PPIVM is actually your extension test, but what you're doing is overpressure on it. And this is why it gets difficult. It's much more difficult trying to control all that and then doing a physiological overpressure rather than the PAVM, which is a lot easier, or the PA in the extended position or the flex position, come to that. Okay, which is why I don't do this inside lying anymore. I just don't do it. Is that okay?
Yep, thank you.
Okay. Yesterday, I had a velocity-dependent weakness at L2, found flexion hypomobility L2-3, addressed the L2-3 weakness, and the weakness improved. Okay, so we sort of talked about this on the Zoom session, I think. So what I said was that segmental facilitation isn't the only type of neurophysiological problem that is velocity dependent. It's probable that most neurophysiological weaknesses are velocity dependent. Certainly reflex inhibition is. If the faster you do that, the easier it is to pick up the braking weakness. Okay, if you give them a chance to set themselves, then it becomes stronger. So you can't use velocity as a differentiation between segmental facilitation and reflex inhibition, but you probably can use it when you're talking between segmental facilitation and radiculopathy. Is that all right?
Yes.
Okay.
So then what would you use to differentiate between reflex inhibition and then the
reflex, well, it's not just the contraction, but reflex inhibition is local, segmental facilitation is through the segment. Reflex inhibition will give you a braking weakness, segmental facilitation won't. And reflex inhibition will give you hypotonicity, and segmental facilitation will give you hypertonicity. As well as that, if you wobble the spine, let's say we've got reflex inhibition at, I don't care, quads, and I wobble L3, that won't make any difference to it at all, but it will if the quads weakness is caused by segmental facilitation. So I can get rid of the weakness and the tone changes from segmental facilitation by wobbling non-locally. Reflex inhibition requires local wobbling. So there's a whole bunch of differences, not just the contraction speed. All right. Is that okay? Bigger pictures, bigger picture. And this is a problem we're working, is that me? Yeah, it was, sorry. Sorry. I did that at a course. I'm standing there and an alarm went off. This is last weekend. And the alarm went off and I went, oh, that ain't good. It sounded like a fire alarm. I'm standing going, what the hell's going on here? So somebody went, it's your phone. I went, oh, shit. I don't know my stuff. Okay, so is that okay? So don't look at one thing with these. There are similarities, tone changes, but one's a different tone change to the other one. Weaknesses, one's a different weakness to the other, and so on. But local versus segmental distributions is probably the biggest one. And your wobble. Would I give an example of how Marissa's verbiage might have been tied out? And I can't remember what you said, Marissa. But let's say this is a flexion hypermobility. Okay, you've got a flexion hypermobility of the right that had to be manipulated. It sort of came out that way. The best description for me, the most what's the word I'm looking for here? The most constrained definition where you can get everything in is that you have an extension subluxation of the right facet. So instead of talking about hypomobility and that basically sums everything up. You know it's a subluxation, you know what the end field would be, you know what the optimal treatment is, and you know exactly what you're going to manipulate and how you're going to manipulate just from that. So actually it was your question, Deb. But Marissa, can you remember what you said? Or Deb, can you remember what she said?
Hey, Jim, it was along the lines of like the velocity dependent, really in or out that segmental versus radiculopathy.
Okay. All right, it's not how I remember it. But I answered that one earlier. Is that okay? Previous question about radiculopathy, segmental facilitation, reflex inhibition. You okay with that?
Yeah, that makes sense to me.
Okay, great. So language is really important. The clearer you make your language, the clearer your thought processes are, and the better everybody understands you. If you can get your thought processes down and have really restrained definitions so that you can get put all the information in as few words as you can manage, you're doing well. Okay, from Marissa, so what you're saying is segmental problems have muscle tone increase, not hypotonic. No. It depends on what you mean by segmental problems. If you mean segmental facilitation, then yes, you're correct. If you mean a segmental dysfunction, then not necessarily. A segmental, whether you have reflex inhibition with hypotonicity or facilitation with hypertonicity, really depends, in my opinion, on the amount of nociception present. If you don't have enough proprioception, you're going to get reflex inhibition. If you are going to have enough proprioception, then you will have segmental facilitation. So you can have a segmental dysfunction that produces reflex inhibition that will only be seen at the segment, not throughout the segment, but at the spinal segment, so the multifidus and any other muscles you want to talk about that are local to that segment. If this is segmental facilitation from a spinal problem, then you'll see the effects of that throughout the segment. And it just depends, I think, on the amount of nociception present as to whether this is going to be reflex inhibition or not. Remembering that the problem with segmental facilitation is its definition, or the cause of its definition. It's put out as prolonged aberrant input. And everybody says that. Everybody said this is prolonged aberrant input, but that doesn't explain how you can get reflex inhibition. Because if prolonged aberrant input gives you segmental facilitation, you should never have reflex inhibition, but you do. So the definition must be wrong. It can't just be any aberrant input. And you've only really got two types of input apart from spectral senses. That's nociception and proprioception. So that aberrant input can't include proprioception because reflex inhibition is defined as inadequate proprioception or caused by inadequate proprioception. That only leaves nociception for segmental facilitation. Is that okay? So you can have a segmental dysfunction that could give you segmental facilitation, but it could also produce reflex inhibition depending on the level of nociception, I think. You okay with that?
Oh, that sounds good.
Sorry, Marissa, can't hear you.
That's good. My internet's terrible.
Okay. I have a college rugby athlete that would benefit from a subtalar manip injury while playing. She is still swollen, has stable ligament stability with normal infields of subtalar and talocrural joint. However, she is still swollen 3 days ago. How soon can I manip the ankle? My main question is, when is it appropriate to manipulate a joint sports injury? There's a follow-up to that, but let me answer that first. Or actually, I think I followed it up separately. It doesn't matter. If the end fields are normal, why would you want to manipulate? The indication for manipulating the post-traumatic ankle are. So what she did was she miswrote, and she meant to say the subtalar end fields were abnormal. So this is my answer. The indications for manipulating post-traumatic are there is no fracture, an appropriate abnormal end field, you have permission of the patient and the area will tolerate it. Otherwise, I don't think it matters how swollen and acute it is. If it will tolerate the manipulation, probably the sooner you manipulate it, the better. But remember that if you don't manipulate it and it's that bad, they're not going to stress it. If it's that swollen and that painful, they're not going to be walking on it. They're not going to be reaching over it. They're not going to be doing any of this thing. So it's reasonably safe to wait while you get the inflammation down. But it's not really necessary. In fact, manipulating the joint can radically increase the time, or decrease the time it takes for that inflammation to subside, especially if they are weight bearing on it. So it's not a matter of time, and I don't really think it's a matter of how much inflammation is present. Those other factors come in. Just make sure there isn't anything in there with a contraindicator manipulation, that you've got the right end field, and you've got that end field when you do the manipulation, and you're away. Is that okay? And the last question, if you get a cavitation and set up a patient for a manipulation, do you always fully complete the manip? So no, and I'm going to answer it now. If I set a patient up and it clicks, all right, you have to assume that it was an effective manipulation. Because if not, if it was effective and you re-manipulate it, you're now manipulating the normal joint. So you have to assume it's an effective manipulation. Get them up, look at range of motion, look at the end fields on the joint. If they're all better, if everything's improved, particularly their range of motion, they feel better for it, then that's it, you're done. Now, when they come in the next time, as far as manipulation, you do anything else you want, but I'm talking about the manipulation. If they come in the next time and say, that's really good, it's been fine since then, you're good, you're golden. If they come in and say, you know what, it was really good, and I was bending over doing my shoes up and it suddenly caught me, or I woke up in the morning, it was there again, then you did a mechanical effect, just wasn't very good. If they come in and say, yeah, that felt better for a few hours and then it gradually got worse, then what you had was a neurophysiological effect. Under those circumstances, the next time you set them up to manipulate it, if you get the same click as you had previously, manipulate it. Otherwise, this is a game you can be doing for weeks on end. So if it's exactly the same click, just go and manipulate it. Is that okay?
Yeah.
Okay. Okay, that's all the questions I had. So do you have anything from your classroom that you want to talk about? Let's get that one out of the way first. Everything.
Do you always do a exam before you're actually doing a objective exam or not?
Sorry, a subjective exam.
No, the scanning the scanning exam and then
No,
before you do the actual
no,
operative?
no, we've been trying to make that point. The point is not to gather too much information that is not focused on what you think the problem is. When you do a scanning exam, all right, let me ask you the question. Why are you doing the scanning exam? Before you actually
Because we were
look
told
at the, yeah, but why? I know you taught that in class, but why? If I've got a patient coming in with lateral elbow pain, then that means you've got to do a full cervical scan, yeah? Before you actually look at the tennis elbow. Is that right?
yeah.
What's the purpose of that?
Well, it's not. It's a waste of time, actually. But
Yeah, that's exactly it. It's not only a waste of time, but it confuses you. You're gathering a lot of information that is probably not relevant to the elbow. Or if it is relevant, you don't know what the significance of it is to the pain they're complaining of. That's not to say you don't do that, but you do it for a different purpose, not for the diagnosis. So if you're doing it for etiology, for example, you can't look for an etiology when you don't know what the pathology is. Yeah. So there's not a lot of point in doing a scan examination on everybody who comes in before you do the diagnostic exam. There's a reason to do the scanning examination, but it isn't a diagnostic one. And that's got to be your first thought. What's the diagnosis here? Yeah. And I agree with you, it's a waste of time. 90% of the time, this is going to be a complete and utter waste of time. Now, was you taught this in school?
To a certain extent,
It's pretty routine.
but not like,
Yeah.
I don't think, well, we were just for like a scanning exam for like a full body, but I think it's just more for just to gather information, but not for diagnosis purposes.
Yeah, that's a whole point. When you're gathering that much information, you end up being overwhelmed by the amount of information you get. And this is where anchoring occurs, the anchoring bias. It's the first piece of information that makes any sense to you at all. You grab hold of it and you do not let it go. That now is your piece of floating wood. Stop you drowning, and you do not let that go. And this is well established, this anchoring bias, and this is why there are so many misdiagnoses. So yeah, it's not worth doing that. And the thing is, you'll never see an expert do that, ever, ever, ever. No expert would even think about doing that. So you're being taught to be a non-expert, basically. The whole point in this script focused hypothetic abduction is to avoid that. So the patient comes in, gives you their symptom and where it is, and that's your hypothesis basis. So you make a hypothesis and you ask questions focused on the hypothesis, which is what the essential illness script is about. And then you either prove or disprove the hypothesis. And if you disprove it, you move on to the second hypothesis that fits those answers and tests better than your first hypothesis, and so on and so on, until you manage to prove the one that works. Now, I'm using prove and disprove very loosely here, but maybe refute and accept it are better terms. But that's exactly what this script focus abduction is all about, is getting rid of the chaff and only having the wheat. Get rid of the crap. Do it later on. Like if I've got a tennis elbow and I'm going to manipulate the neck to help the tennis elbow, then I'll do a scan and examination of the neck, because now I'm worried about everything up there, the stability of the upper joints, VBI, and all the other stuff that goes with it. So the scan examination isn't thrown out. It's used to say, is it safe for me to treat this? Also, you can use the scan examination as a completion of the whole exam. So if you're worried about premature closure, then you need to do everything, basically. Or if, yeah, you're doing differential diagnosis, even differential diagnosis, you don't need the scan examination. You only need 1 or 2 tests to refute or accept a differential diagnosis.
So you're doing like the scanning exam, like one of your hypotheses could be, cervical related, just to rule in or out cervical involvement for like an elbow pain?
No, now you're looking at etiology. I've made the diagnosis of tennis elbow. So the question is this part of cervical involvement? So one of the things that's going to cause a tennis elbow, the main things are weakness in the extensor muscles. That leaves the tendon very vulnerable and the muscle vulnerable. So I'm going to look for evidence of segmental facilitation, which isn't necessarily from the cervical spine, by the way. I'm going to look for evidence of segmental facilitation by looking for segmental weakness that's not fatigable, that is hypertonic, and so on. And if I find that, then I'm going to see where the segmental facilitation is coming from. Now, that doesn't mean doing a cervical scan. That means seeing if I can make these nociceptive joints that are quiet loud. So I'm going to do things that's going to convert nociception to pain. So the patient can tell me if they've got pain in the shoulder. So quadrant testing in the neck, I can do quadrant or figure of 8 testing there, and so on. So I identify the cause of the facilitation then, or the area of the facilitation, and then I'm looking at, I'll come back to that in a minute, Kelsey. Then I'm looking at what's wrong with the joint that is producing the segmental facilitation. So then I'll do a local exam on the joint. So at no point during this process have I looked at the spine as far as the scan's concerned when I'm looking at etiology. But if I'm going to manipulate the neck, then I need to know if it's safe for me to do that. Otherwise, I can't remember the last time I did a complete scan outside of a course. And I haven't done that in a long while neither, because I teach the scan in bits and pieces according to what their diagnosis is. So doing a complete scan, I think, is, and I used to teach it that way, but I don't anymore, because it takes time. I'm not worried about you wasting time. I'm worried about the amount of information you're getting that is irrelevant to the diagnosis.
Jim, how long does it take you to do the scan exam without the special tests?
Well,
How long should it take you?
What? So you're talking about leaving out
Lumbar
phalanx and that? In the
spine.
cervical spine, it's probably
Yeah.
about 7 minutes.
Okay.
But it's not the time, it's the information you're taking in. So if you want to do a scan, do it after you've made the diagnosis and not before. Otherwise, that's going to confuse your thought process with the diagnosis. It's really not the time. It's how much information you're getting that is completely irrelevant to the patient's diagnosis.
Yeah, and for, yeah, Jim probably have a different opinion on this, but for me, I can do the scan exam exactly as Jim said. After I made the diagnosis, heck, I might have already treated the diagnosis. It's a search for etiology and information, and it's a fast way to get all the documentation I need to properly document the case.
There you go.
Because I get my active range of motion, passive range of motion, I get strength, I get everything in a nice, tidy, quick package.
Well, what I want to know is,
So it may not be the first thing I do.
yeah, what I'd like to know is if you do a scan and you find odds and ends that are not related to the diagnosis, what do you do about those odds and ends? If it's not related to the diagnosis and it's not related to the etiology, what do you do about those odds and ends? Restricted shoulder movements, restricted thoracic movement. What do you do about this? If you treat them, you're running the risk of making an asymptomatic joint painful. But yeah, I would agree with you. Don't do this as part of your diagnostic exam unless the diagnostic exam suggests that this is a disc herniation. And then your scan, because that's really, this is what the scan was. The scan was designed by Syriacs. The whole exam was designed by Syriacs. And Syriacs felt that every problem in the spine was caused by a disc herniation. Now, that's exactly what we thought. So sacroiliac joint problems didn't exist. Facet joints, well, I don't even know what they are. We'll ignore them. So everything was a disc herniation if it wasn't a fracture or arthritis. Okay, so the scan is designed for disc herniations. Myotome, dermatome reflexes, it's in the name. You're not even looking for, it doesn't include the spinal cord. It's always myotome, dermatome, reflexes. And this is why, because he concentrated on the disc. Now, if we take that into modern days, it isn't the disc. We know it's not the disc. In fact, disc herniations are really quite rare in our experience, and compared to everything else, it's not the most common thing you get in your clinic. So doing an exam that was designed for a disc herniation seems to be a bit pointless. Now, if you want to talk about selective tissue tension testing, that's a different animal. Selective tissue tension testing is the basis of the scan. So active, passive, resistant, and so on, stress, they are selective tissue tension testing, but Syriacs put all that together in a scan. So the total exam for a disc herniation is a scan, and that includes active, passive, resistant stress testing. Okay, so it's historically accurate. Now it's personally, I think it's counterproductive. That's probably the best way I can do it. Focus on your hypothesis, and then you'll get to pattern recognition much faster, guarantee it. Which is your ultimate aim, is to have pattern recognition fairly universal. Dave, you don't do any of this shit. You go straight to pattern recognition. Yeah.
Correct. You know,
I mean, basically, you're making a diagnosis in 15 seconds, 20 seconds.
Yeah, and you know, if I use the scan exam, it's more, as you said, it's search for etiologies.
Yeah.
And it's bias correction.
Yeah. I would say, you know what, though, I think probably we need to get rid of the term scan, because you're using selective tissue tension testing rather than the scan as a whole.
Yeah, correct.
So it's a term that's wrong. So use selective tissue tension and use it in a focused manner. Okay, Jenna?
Yes, thank you.
Okay, Kelsey, I missed your chat, but what was it? Save me trying to find it, because that's always futile. Have you left because I ignored you, Kelsey?
We have a poor microphone.
Okay, let's have a look. Okay, sorry. Chat then. Oh, I've got 10 of them. Okay, can you review the difference between PPIVMs, not, okay, PIVMs and PAVMs. PIVMs is generic. It means you're doing a passive intervertebral movement that includes the PPIVMs and the PAVMs. That's generic. PPIVMs is a passive physiological movement. So this is flexion, extension, side bending, and so on. So this is exactly what you're doing when you've got them laying on this side and you're doing flexion, extension, rotation, side bending. Yeah. The PAVM is a joint glide. So this would be a supro-anterior glide of the inferior vertebra in extension under the superior vertebra to check the glide of extension. So the PPIVM tells you if it's hypomobile, the PAVM tells you if it's articular or not. So when you're doing it from position testing, the PA on the posterior transverse process is the PPIVM. The supro-anterior glide on the transverse processes posterior is a PAVM. So you don't do a PAVM if the PPIVM is negative. You only do a PAVM when the PPIVM is positive. That's telling you it's hypomobile. Now you want to know which type of hypomobility it is. That good?
Crystal clear.
Thank you. Suck it and see it means try it and see what happens. Yeah. You've never heard of suck it and see? It's the only way to get experience. Suck it and see, whatever it is.
I haven't, but I like it and I'll use it.
I don't know where it came from. I've got a feeling it was probably something filthy. There's the trouble. I can't get this up. Can you review the difference in hand placement during side bending and rotational PPIVMs? It depends on how you're doing the side bending. Typically, if you're doing the rotation, then you're pushing the shoulders back. Is that how you learned it? Actually, this is general for PPIVMs anyway. So if I'm palpating movement, I want to feel something moving into my hand, preferably rather than it moving away from my hand. It's easier to feel. So if you're testing rotation, you want to palpate two spinous processes, adjacent spinous processes. Now you can do that with two fingers or one finger. You can put one finger under both of them, or you can put a finger under each one, and then you rotate the shoulders backwards when you're feeling for the superior one to push on your finger before the inferior one. If they both push at the same time, it's hypomobile. Now, this is one of the problems with doing this, is because generally speaking, you can't be sensitive enough to feel discrepancies in the amount of movement that's occurring, just that one is moving separate from the other one rather than how much it's moving separate from the other one. That's one of the problems with it. But you palpate under the spinous process to feel it moving in your finger. If you're doing side flexion, again, it depends on which way you're doing it, but I would palpate under the spinous process again, because what's going to happen is they're the two spinous processes, they're going to do that. And you can feel these closing on your finger. If they come down together, then it's hypomobile again. If you're doing it the other way by bringing the pelvis up, then you want to feel on top of them because they'll be doing that now. Is that okay? Who was I answering for? Isaac, that was your question. Is that okay? Deb, you've got shitty Wi-Fi. I can't do much for that for you. Okay. All right. It's from Kelsey. When we were talking about potential multi-level lumbar involvement as a red flag, especially posterior, post MVA versus exacerbate what? I'm not sure what that means. When we are talking about potential multi-level involvement as a red flag versus exacerbation of knee pain with lower extremity weakness, are you ruling out lumbar involvement with paresthesia? I don't know what that means. I'm sorry. First off, yeah.
The only thing I could think she's trying to ask is that, okay, how do you rule if you have these two competing diagnoses, how do you rule out the one from the other?
Well, you're going to get local signs at the knee. So if you've got a knee problem, it's when you move the knee around, it's going to be painful. If you've got a lumbar spine problem, it's going to be painful when you move the lumbar spine about. And we're talking not just subjective exam now, but the patient and the knee. The patient, what their functional problems are. So if you're talking about referred pain, if you're talking about referred pain in the knee from a lumbar problem, then almost certainly, very rarely will you have isolated knee pain from the lumbar spine as a referred pain. Very, very rarely. And even then, if you do PAs over the back, over the spine, that's going to hurt them. And if we're talking about significant problems in the lumbar spine, the ranges of motion is going to hurt, and it probably hurt the knee as well. Certainly the knee will hurt after you've buggered up the back by doing your exam. But almost always the knee pain follows the back pain. Now, referred pain is caused, there's four factors in referred pain. One is the intensity of the pain. The more intense the pain is, the more potential there is for referral. How close the source of the pain is to the spine. So the closer, more central the tissue is, the more it's got an ability to refer out. The deeper the tissue, the more referral it can do. So skin tends not to refer. You can put a pretty bad slash through the skin with a razor and quite deep, and you're not going to get much in the way of referred pain. And finally, how long have you had the problem? So the longer you have it, the more referral is that, because that's central sensitization. So almost certainly the knee pain will follow that pattern. So if I've got a lumbar problem that's referring to the knee pain will be worse when the back pain is worse. And as I say, the function of the knee, and certainly the objective examination of the knee, if this is purely referred, will give you nothing. That'll be negative. Pretty much negative anyway. Again, there's some sensitization there where you can get a bit tender around it, but pretty much it's negative for the amount of pain it's having. Is that okay? I don't know if that's what you meant. As far as multi-level lumbar involvement as a red flag, 2 lumbar discs is fine. All right, you can have a single disc hitting 2 nerve roots. The nerve roots are really quite oblique in the spine, in the lumbar spine anyway. So a single disc can hit 2, but you're getting to more than 2 and something else is probably going on. In the cervical spine, it doesn't happen that way because the nerve roots come out much more horizontally, and a single disc really can't hit 2. So probably what you're doing there is confusing a radiculopathy or multiple radiculopathies with a plexopathy, probably. But plexopathies are rare and they're often caused by something nasty anyway. Does that do it okay? Chat, say yes or no on chat, would you? All right. I had a patient who has a history of knee pain but hasn't had it for a long time. His whole left leg is weak. He had a car accident, pretty banged up at his back too. He was walking. Oh, this, okay. I'm assuming, who's this from? Kelsey, okay. All right, so this is your follow-up to the question. I don't know, there's not enough information for me to tell you anything about that. But if you're looking at differentiating local pain from referred pain, your best bet is an objective exam. Just grind the knee around and see what it does. If he's getting significant pain when you do that, he has a knee problem and a back problem. Okay. How accurate and sensitive would say a PPIM is to a non-expert to diagnose subluxation versus muscle tone? And I'm getting a feel for it. I'm having a hard time being confident on whether I'm actually seeing what I think. Okay. I really don't like testing inside line. I find it's really difficult to do. This is just a matter of opinion, difference of opinion between me and Eric. I think your best bet is to test from position. It's easier to do. You've got no distraction. You're not trying to support legs, move everything around. Anyway, having said that, you do have problems with testing position and then testing through the muscle tone if it's high tone doing position testing. In that case, you're better off doing this inside line. And PPIMS is quite difficult to do. I would concentrate on the PAVM if you're having trouble feeling the PPIVM. So look at the glides that you're doing. So you can stabilize, if you're doing flexion, for example, put them into the flex position. So they're in flexion and then stabilize the inferior vertebra and push on the spinous process of the superior and push that supro-anteriorly to get the PAVM for flexion. I think you'll find that easier than feeling the PPIVM. And it's specific for the joint. In extension, you stabilize the top bone and push the inferior bone supra-anteriorly to test the glide for extension. That's what I would do. You can do it in rotation, you can do it in flexion extension. It's really difficult to do it inside flexion, and I wouldn't worry about it, but you can do it in those two positions. So I would concentrate, which is what you're supposed to be doing anyway. If you're looking at whether you have a hypomobility and you don't know whether it's articular or not, which you don't, test the PAVM. It's easier to feel the end feel with the PAVM than it is in the PPIVM doing it inside lying. Okay, but the PAVM you should be doing anyway.
Yeah, I mean, both, I think the position testing should set you up where, if you're flexing forward and they're in the end range position to test the PAVM, at that point, actually, there shouldn't be a lot of muscle tone unless it's abnormal tone. And it should be fairly similar with the prone extension position, as long as they're not trying to extend using their paraspinals. It should be a position of reduced tone. Of course, they may have pain and can have an abnormal toning pattern, but those are probably the best positions if you find that your muscle tone is inhibiting your end feel.
Yeah, the only problem you got there is you can't feel the asymmetry in the rotation. But if you're going to do that, you need them in extension. Yeah.
Yeah.
So either in sideline or in prone, as you say, but you need them in extension and do the glides. Are there certain questions you ask right away for every patient develop hypothesis of each diagnosis? No, 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 no. Every patient's different. Your hypothesis is determined by where their pain is. This isn't me saying this. This is what your brain does. Patient walks in, we can do it. Patient walks in with medial knee pain right now. Tanner, what's your hypothesis? Right now, straight off, medial knee pain. Pick one.
MCL.
OA.
All right, okay, fine. MCL, medial meniscus. You immediately have a hypothesis. Patient walks in with suboccipital pain. What's your hypothesis? Quick.
Segmental dysfunction.
Sure, why not? Fracture, I don't really care. But you immediately have a hypothesis. Your brain does that, it's immediate. What's happening is your conscious is getting in the way because you don't want to look stupid. Your brain is saying, don't do that because that's stupid. Your brain is saying, this is an idea, test it. So your hypothesis is there. There is no other questions. It's where the pain is. Then you ask questions based on the illness script for that hypothesis that you have in your head. So if it's a segmental dysfunction, have you had it before? How bad is the pain? All the questions that will focus on that hypothesis. And that's a natural thing to do. So your hypothesis and your questions follow each other along quite nicely if you leave them alone. But you're trying to impose things like the scanning examination and safety questions and all this stuff on what your brain wants to do. Let your brain do its work. Yeah. So there's no particular questions. There's no particular way of doing an exam. You're actually going to get a videos on this next time talking about if you've got particularly where you've got post trauma. It's on a post neck trauma. How you go about it? Well, in this case you change a little bit. Your hypothesis after trauma should be, okay, this is a fracture. This is a bleed. This is VBI. You basically, they're null hypotheses you're setting up to fail. So you're going to try and disprove these because it's so dangerous. So that's the only time it does happen. But you've now got a rule that if there's a chance of serious pathology, like a significant chance because of the history of trauma, then you change that and you go for a null hypothesis. Otherwise, your brain will do what your brain does, and that it seeks patterns. Your brain looks for patterns. It does it automatically. Your job is to find out if it's right or not and test the pattern. That's it. Okay? Now, what's this one? Okay, what would you recommend for doing a oh God, I've lost it. I hate these things. What do you recommend doing for a patient who has both a disc protrusion with radiculopathy and a significant stenosis? Okay, first off, it's unlikely that a protrusion will give you a radiculopathy. They're not big enough. These are bulges in the disc that are probably not big enough. So you're looking at a prolapse, an extrusion, or metaplastic proliferation. Probably not a protrusion. Protrusion might give you dural signs if it's big enough, but it's not going to produce a radiculopathy. And they got significant stenosis. Well, the stenosis, let's see, he's unable to do what? Yeah, well, you can't do an extension. This is the thing. You can't do an extension exercise with a disc herniation anyway. The disc won't let you do it. Now, if the question is about protrusion that's causing dural problems rather than a radiculopathy, then, and it's probably not going to happen anyway, because if they've got significant stenosis, then they're unlikely to have a problem with their disc because they're going to be older patients. But given that, we can go to probably a better explanation. If you want a real problem, it's a patient with a spondylolisthesis and a disc lesion. I'm not going to say it's herniation, but a disc lesion. And if you want to do extension exercises with them, you're going to have real problems. And you won't be able to do it. Almost certainly you won't be able to do it. So you're going to have to do other stuff if you can. Now, with a protrusion, you can try mobilizing it. Might be possible. But more likely, what you're going to end up doing is trying to deal with the inflammation. There's probably inflammation there. If you're getting dural signs from this, it's probably inflammatory. So you get rid of the inflammation and see what happens. But if you want to do extension exercise and the patient can't do extension exercises, you can't do extension exercises. Find another way of dealing with it. Because you really can't change the stenosis. Is that okay?
Yeah.
Oh, we'll bugger it up again. Is that okay? Who else that? Okay. Basically, this is a problem. Nobody's told you how to treat stuff that you can't treat. Nobody's told you how to discharge a patient that isn't better, have they? The impression you get from school is you can treat everything successfully, and it's just not true. Now, you have to work around problems that the patient has that you can't change. There's a certain amount of reality that you have to deal with that they really don't talk about in school. But one of my biggest problems is spondylolisthesis that's really crapped up the disc as well. Will we get EISs for every area of the body? Yeah, but you're not going to get them for every condition. And really, you know, this is to help you out at the beginning. The whole point of this is for you to realize that you have EISs of your own. Now, it takes time to develop them, but you've been in practice now for quite a while, haven't you? I mean, I would guess that most people have been out of school for 2 years at least. So you've already got illness scripts for the patients that you've seen, the conditions that you see. The point of this is to give you some guidance now and for you to come up with your own EISs and then get basically to test them on the instructors and see what the instructors think of them. And that's the best way you can learn this. And then if the instructor said, no, that's not a good one, then your question is, why not? And your follow up to that is, this is what I see. And then the instructor should be explaining to you why you're not seeing what you're not seeing. And good luck with that. But this is all about you developing your own skills and your own illness scripts, not just essential illness scripts, but illness scripts. I think probably the difficult part about forming an essential illness script from an illness script is actually determining what's specific enough to include, because you really don't want too much. You want to keep this as terse as you can. That's why you'll keep hearing this all the time. 4 questions, 2 tests. The shorter this is, the more specific it is to that condition. So yeah, I'll give you illness scripts for each area, but they are there for you to modify as your experience improves. Or if you failing that, to question the illness script from your experience. Actually, that's what you should be doing anyway. I don't see that. Why don't I see it? And then make me justify the essential illness script. rather than just swallowing it. I think what I might do is throw a couple of dud ones in there as well, just to keep you on your toes. That'll teach you. Oh, he's got an extrusion. All right. Yeah, don't worry about the stenosis. he can't do extension exercises. Period. The disc won't let it. If he's got an extrusion, he's extremely rotoscoliotic and kyphotic. You've got zero. I can pretty much describe this guy to you. He can't walk. He limps. He can't bend backwards at all. He's kyphotic, so you get not just 0 degrees of extension, you've got minus n degrees of extension because he's already bent forward. You cannot do extension exercises with it. Can you? Who was that? Sorry. Michelle. Is that what he looks like? Okay. Yeah. I mean, if he has an extrusion, it's the worst possible case you're going to have walk into your clinic. These are the best thing you can do with this is to protect him, stop the pain as quickly as you can. If you can put some sort of back support or even taping, if you can do something to reduce that pain, give him information about not aggravating the thing, rest positions and so on. Try and get the inflammation down, then you may have a chance of improving him. Otherwise, if you try and work on this mechanically, it ain't going to work. These things don't go away like that. You need to get rid of the inflammation. Okay. I would say then his presentation is odd, mild to moderate pain. He has fatigue and weakness. His extension is only mildly limited. The extrusion then, I assume, is a radiographic finding. Yeah, I would suggest that his extrusion is probably coincidental. And the weakness is segmental. C5-6. Okay, well, they don't extrude. There really isn't such a thing as an extrude in cervical disc because you don't have a nucleus in cervical discs. I bet you what that is stenosis with some disc impingement. How old is he? 45. That's young, isn't it? I would question the radiograph. That's an MRI. I'd question that as it being a major player in this. So, sorry, I was thinking of the lumbar disc. What was you doing with him? Traction? Yeah. How's it going? Okay. Yeah. Let us know how it does, okay? I would think probably the MRI is wrong anyway. An extrusion is escaping of the nucleus. He doesn't have a nucleus. Unless he's a complete freak, he doesn't have a nucleus. So the diagnosis is wrong anyway. So he's got some enlargement of the disc, and it's unusual to go posterolateral like that. They usually go posterior. This is C5-6. The uncinate process can be small and atrophied. Did they mention degeneration on the X-ray? Yeah. Okay. Traction. Really, that's probably your best try. See what happens to the weakness in particular. But I would. Well, it's not a disc. Well, it's not a disc extrusion anyway. You're welcome. Let's have a look. I think that's it. Is that it? Yep. All right, guys. Anything else before we finish up? Got a minute. All right.
No, thanks, Jim.
You're welcome. I'll see you all next week. If I haven't slit my throat by that time. Nobody misses me anyway, so what does it matter? See you guys.